Hi friends, I am Dr. Pratap Sinato. I have done MD in forensic medicine. In today's video, we'll continue with molecular autopsy. In that, we'll start with internal examination of body. Usually, internal examination start with the cavity chiefly affected, but in some cases, like in suspected cranial injury, the skull should not be opened first before blood has been drained, opening the heart. In other situations, like in other cases also, usually whatever the organ affected can be dissected, but usually there are different methods of removing the organs which is followed. There are different methods of removal of organs or evisceration methods. First is Virchow's technique, Rockingham technique, Latimer's technique, Grohn's technique. Coming to Virchow's technique, here in this individual organs are removed one by one, like stomach is removed from one part or brain is removed separately and dissected out. Cranial cavity is exposed first, followed by thoracic cavity organs and abdominal organs. Then spinal cord is removed from the back. In this anatomical pathological relations are not preserved. So here the individual organs with their relations with the nearby organs is not preserved, and each organ is removed separately and dissected. In Rockingham techniques, it involves in situ dissection. So here the body itself, the lung is dissected and examined, and stomach is dissected and examined in combined with en bloc removal of each organs. So it is preferred choice in patients with highly transmissible disease like HIV or hepatitis B, in which the organs are dissected in situ in the body itself. Latimer's technique, this is the technique which is commonly preferred. Here cervical, thoracic, abdominal and pelvic organs are removed en masse and dissected as organ block. So here the tongue, esophagus, stomach, the liver, the lungs, the liver, spleen, then intestines, then pelvic organs are removed as one single en bloc and dissected out. It has advantage of leaving all the attachments intact, and any injuries, like if there is a injuries is present and how it can be tracked easily, like if the birth of injury is there, each hole can be transmitted, can be detected, and then each organ's relationship with each other can be easily maintained. In Ghon's technique, cervical, thoracic, abdominal organs and erogenous systems are removed as organ blocks. So here the system is removed as organ blocks, like lung is removed along with trachea, then stomach is removed along with intestines, like organ blocks are removed one part, like a one part systems. Nervous system is removed as another block. So Ghon's technique, the one system is removed in a part and dissected. So these are the four techniques, and among them Latimer's technique is the common and commonly done, and this will be the common which will be discussed in this video. So coming to dissection, first the abdominal incision. The dissector usually stands on the right side of the body if he is right-handed, or left side when it is left-handed. Then incision is taken, suitable incision, like in last video we discussed about I-shaped, Y-shaped, then modified Y-shaped incisions. So common is the I-shaped incision, which starts from the chin and till the symphysis pubis, avoiding the umbilicus. Umbilicus is avoided since reconstruction is very difficult, so it is done. So taking the incision is taken and skin is reflected on the opposite side. So once this skin incision is taken, the skin incision is up to muscle deep. So usually till the muscles and all the skin is taken, incision is taken, and the skin is reflected on both the sides. After the skin is reflected, as you can see in this image, till the muscles, intercostal muscles can be easily seen. These are the recti muscles which can be seen, and recti muscles, and these are the intercostal muscles. So intercostal muscles present, the skin is reflected on the muscles can be easily visible. After the skin is reflected, recti muscles of the abdomen are divided about 5 cm above the symphysis. So here the incision is taken up those recti muscles. Then recti muscles are separated on each side opposite end. Then small cut is made in the fascia big enough to admit left index and middle finger palmar surface up inside the abdomen. So once the recti muscles are separated, using the index and the middle finger like a V shaped, it is inserted into the abdomen to dissect the peritoneum. The fingers are separated in V to protect the underlying structures, and and the sharp blade knife is inserted between them and the peritoneum is cut to the zippoid. So in between the fingers, the peritoneum is dissected along the till the zippoid peritoneum is dissected. With using the fingers, the peritoneum is lifted up, and along that to avoid damage to the underlying tissues, the incision is taken from below upwards. The thickness of the fat in the abdominal wall is noted, whatever it present first after that reflecting the recti muscles and peritoneum. The condition of the abdominal cavity and organ is observed before anything is disturbed or altered to find out if there is any blood, pus, fluid in the cavity or perforation or damage to any organ. So, after peritoneum is separated, underlying tissue is observed for any pus, presence of blood, bleeding, pus, anything abnormality is present, perforation is present, has to be noted. If blood or pus is present, then it has to be connection is made and it is preserved. Any abnormalities, position of the abnormal organs, adhesions, old operations, pathological processes, injuries, then height of diaphragm in relation to ribs is noted. So, all the ribs position, any adhesions are present, any injuries are present like incision mark, laceration mark has to be noted and photographed. The peritoneum is examined for adhesions, congestion, inflammation, exudation. So, this is the dissected part. So, here the peritoneum is separated and this is the stomach, this is the intestines. So, here the till the zyphisternum, the peritoneum is dissected. Then if any abnormality is present, has to be examined. Course, direction and depth of injuries, if any, is traced. Any foreign objects, bullet fragments, knives, etc. identified and labeled, and external injuries if present is noted. Any injuries, abnormalities should be photographed for better documentation with scale and identification number. So, usually if there is an injury is present, it has to be photographed using a present of a scale. So, one scale has to be placed along the photograph and a flag should be placed with the identification number. Usually there should be a number along with the year of the number. The number will represent the whatever the case number is present. So, PM number will present and the year which we done. So, this should be present in any photograph. This minimum, these two things should be present along with the injury which is photographed. Then greater momentum lying across the small intestine is pushed upwards across the liver. After the peritoneum is removed, the momentum is separated. The upper part of the small intestine is grasped in the left hand and followed upwards until it disappears at to peritoneum to become the duodenum. So, hence the peritoneum is opened, the stomach, intestines and has to be dissected out. The small intestine is opened with the left hand, followed upwards to disappears into 2.2 till the duodenum is found out. The mesentery is penetrated with the point of the knife at the duodenal genital flexure and the two pieces of string are passed through the hole. So, usually to dissect the stomach and dissect the intestines, usually a string is useful which is placed in the duodenal junction along the line and they are brought upwards and tied separately and tightly around the gut. The gut is divided between these two ligatures. So, usually to preserve the contents of the stomach and preserve the content of the intestine, so first at the duodenum, two strings are tied, one at both the end, and usually the incision is taken along between the two incisions. So, between two strings the incision is taken. It is also done in both the sides, both on the upper end and lower end. So, two strings are placed tightly and in between two strings the incision is done. So, this is similarly done in the stomach and also is done in the small intestines. The coils of the intestines pull forward by the left hand and the mesentery is cut close to the mesenteric border of the gut and until the ileocellac is reached. So, intestine has a mesenteric border. So, the mesenteric border is identified and this mesenteric border is useful for is followed until it reaches the ileocellac wall. So, the intestines are palpated for any abnormalities, any presence of adhesions along the mesentery and until the cecum is mobilized and ascending colon is pulled up forwards and medially by left hand and its attachments with the posterior abdominal wall are cut with the knife up to the hepatic flexure. So, intestine is followed till the colon is reached and till then the again the colons is reached and the intestines are usually separated with the abdominal attachments. Then momentum is pulled down. Then transverse mesocolon is cut through with the knife until the splenic fissure is reached. So once the transverse colon, then uh, ascending colon and descending colon is separated near the splenic fissure, the momentum separated, then ascending colon is separated, then transverse colon is separated, then descending colon is freed in the similar manner until the sigmoid is freed. So each and every intestinal part, small intestine, large intestine, are freed from their abdominal adhesions. So any abdominal adhesions they are present are dissected out whenever they are separated. The upper part of the rectum is mobilized and cut through between two ligatures below the brim of the pelvis. So again similarly near the rectum, so near the rectum also there two ligatures are placed, one above, one below, and between two ligatures it is cut and it is placed so that any content which is present inside the rectum is inside the large intestine is preserved. The whole of the small intestine and large intestine is removed from the abdominal cavity. So the entire small intestine, large intestine comes out, is dissected. Now coming to anterior towards the head, to dissect the neck, a block of 12 to 20 cm high should be placed under the shoulders to allow the head to fall back and thus extend the neck. So wooden block is placed near the neck and head is fall down below the, so that the neck is clearly visible. The skin is held with the tooth forceps with a sharp long scalpel. This is carried out immediately deep in the skin through the perisma. So eye-shaped incision which extends till the chin is present, then the skin is separated on the both the sides. Then subcutaneous tissue is carried up to the lower border of the lower jaw, while laterally on the side of the neck and clavicle. So the skin is reflected on both the side from the tissues till the muscle area is clearly visible. The deep cervical fascia is incised and reflected from the cervical muscles and submandibular gland. The sternocleidomastoid muscle is freed from its clavicular and sternal attachments and reflected on the each side. So each of the muscle end is cut. Sternocleidomastoid muscle is cut at the attachments. Homohyoid, sternohyoid, and thyroid muscles are exposed, inspected, and reflected on each side. So each muscles which are attached to the clavicle are cut and separated. Thyroid gland, after each muscles are separated, the glands are visible. The carotid sheets are freed by blunt section from their investing in connective tissue. Then the trachea, the glands will be visible that are separated. The larynx, trachea, pharynx, esophagus are mobilized and pulled away from the prevertebral tissue by the blunt section. So the trachea, the larynx, pharynx are held up upwards and pulled upwards so that they are separated from the spine. Later on, the mouth is opened and the tip of the tongue is pushed upwards and backwards with the forceps. Then knife is inserted under the chin. So once the muscles are opened up, trachea is separated, then a knife is used to cut along the mandible. Knife is pushed inside the mandible through the chin to the floor of the mouth and cut along the sides of the mandible to the angle of the mandible, dividing the neck muscles attached to the lower jaw. So one neck is passed inside the mandible and cut along the base of the neck, so base of the tongue. So all the muscles around the base of the neck is dissected out so that the tongue gets separated. Then tongue is pulled outside from the below. Then at the angle of the mandible, blade is turned inward and avoid cutting carotid artery. The tongue is pushed down under the mandibular arch with the index and middle finger. The soft palate is done cut to include the vulva, tonsils, and tongue and neck organs is removed. So tongue is pulled from the mandible once it is dissected out, along with soft palate. The knife is carried backwards and laterally on both sides of the mandiline to divide the posterior pharyngeal wall. So once the tongue comes out, comes out with the soft palate, there is uvula is present, then there is esophagus is present, then in the front there is trachea is present. So esophagus, trachea, and tongue is held up and pulled forward, and along with that, as it is pulled, the pharyngeal tissues which comes out dissected from the behind forwards and laterally, and pharynx is pulled down and upper part of the neck. So tongue which is present is pulled, and as it pulls, the trachea which is present, the esophagus the pharynx is pulled and it is separated from the spine. The dissection is then carried distally through the pivotal muscles on the anterior surface of the cervical vertebrae until the whole of the neck structures are freed to the level of the suprasternal notch. So, tongue is separated till the suprasternal notch, all the structures are removed. The great vessels, including the carotid shade, should be divided in the neck. Afterwards, after neck dissection, chest dissection has to be carried out. The muscles of the chest are dissected away, keeping the edges of the knife directed inwards towards the rib, carried back to the mid-axillary line, down the costal margins and up over the clavicles. So, the skin is separated, the muscles are costal muscles are separated till the axillary muscles. The ribs, sternum and spine should be examined for any fractures. Then the chest is opened by cutting the costal cartilages with the cartilage knife. So, at the costal cartilage junction, it is cut along the ribs. So, if it is in the older individuals, it is bone saw is used to cut along the junction. So, near the sternum and the costocardial junction, it is cut. Next, the sternoclavicular joint is removed on each side by moving the shoulder tip of the left hand, which causes the joint capsule to move. So, sternoclavicular joint, to identify the sternoclavicular joint, the shoulder is smooth, which is shown, and from which it is helpful to cut the joint. The diaphragm is divided at the attachment to lower lips and sternum up the spine. Then the pleural cavity should be examined before completing the removal of the sternum. So, before removing the sternum, before removing completely, so sternum is separated by now the costochondral junction is removed and sternoclavicular joint is cut in the both the sides. So, before removing the sternum, the pleura should be examined for presence of any adhesions. Pulling of sternum and ribs is avoided to prevent negative pressure resulting in the aspiration of air into vessels. So, though it is not usually pulled, so it is dissected out and it is removed. Before removal of the thoracic organs, first we have to examine lumen of the pulmonary vessels, observe the right atrium of the ventricles for air embolisms, state of distension or collapse of the lungs, then pleural cavities for presence of fluid, blood or pus in the pleural adhesions, pericardium for cardiac tamponade, and collection of blood samples from the heart or thoracic examination, toxicological examination has to be done. So, once the sternum is opened, we have to examine the heart, pericardium, pleura, lungs, condition of the lungs, then large vessels, the pulmonary arteries, aorta, then everything has to be examined for any abnormalities before complete removal. So, next, so now we have dissected the neck, tongue from neck, esophagus, pharynx is dissected. In the abdomen, we have dissected till the rectum it is dissected. Now, all the organs from the chest, from tongue to abdomen to rectum has to be removed. So, the axillary bundles which lies beneath the clavicles and the first rib are cut by passing the knife upwards on each side from the thoracic cavity into the neck. Pleural adhesions between the lungs and the chest wall, if any, should be cleared off by the fingers and knife. So, now the chest organs has to be separated. So, in first the behind the pleura, any of adhesions is present between the pleura and the ribs has to be separated. A knife is useful, passing the knife on each side to thoracic cavity on the neck to separate the adhesions. Then fingers is slipped between the both hands on the lateral portion of the one lung and inner side of the chest wall. The left hand works up the apex, the right or down the base, and they meet at the hilum. So, in the lungs, once the lung is present, the hand should be passed from the apex to the base, and if any adhesions is there, and lung has to pull forward. The neck structures are grasped mass in the left hand and pull downwards, cutting the structures the front of the spinal column to the left of the, from the level of diaphragm. So, from tongue, the trachea, then lungs, which are present, then the stomach is present. So, tongue is pulled forward, and as tongue is pulled forward, any adhesions are present near the both the sides of the lung has to be removed. Then diaphragm has to be cut along the adhesions along the sides of the ribs. It has to be cut, and all the organs, tongue along with the lung and stomach has to be removed. Now, the thoracic organs with the heart are pulled back into the thorax, placed. Then the stomach and spleen are pulled medially by the left hand, and diaphragm is removed by cutting through the attachments on the ribs and both ends. Till now, the tongue, neck structures and lungs and heart are separated. Now, the abdominal structure has to be separated. Now, the stomach which is now present. It is cut, it's present, then intestine is also present, then there is liver is present, then spleen which is present here has to be removed. The stomach spleen are pulled medially, the left hand, and diaphragm is removed by cutting through the attachments to the ribs on both sides. So diaphragm is separated first. Thoracic organs are pulled down by the gentle traction on the neck structures, and the cruciate ligament which attaches the diaphragm to the spine is cut. The organs are then put back in the thoracic. Once the chest organs are separated, they have to be put back. Then the spleen and the tail of the pancreas are held in the left hand, and dissection is carried out behind them in the midline. So in the stomach near the pancreas, the pancreas is held upwards and any adhesions are removed. The liver is pulled medially. The liver which is present, it is pulled medially, and the knife is passed behind the structure to free any from attachments. The peritoneum fat cut just outside the outer borders of the kidney, which is then grasped in the left hand and mobilized by dissection behind it to the midline, freeing it from the anterior surface of the iliopsoas muscles. So the peritoneum and the kidneys are now examined. So kidneys are present in the side near the posterior lateral surfaces, has to be separated. Along the kidneys, ureter is identified and freed all the way down to the entry to the bladder. Both the kidneys are then taken in the left hand, and the knife is carried down to the midline behind the aorta to the pelvis. Then the knife is passed around the side of the wall of the pelvis, dividing the lateral attachments of the bladder, each side of the pelvis being dissected downwards to the midline. So we have previously discussed that stomach with intestines already separated. Now stomach is present, then liver is separated, then spleen is separated. Now the kidneys which are present in the along the bladder has to be separated and they are removed. The anterior surface of the bladder is freed with the fingers from the pubic bone. The femoral vessels present near the pelvic in the inguinal regions are cut at the level of the brim of the pelvis. The contents are pulled forward upwards, and the urethra and vagina divided as low as possible. The whole block of thoracic abdominal organs are pulled forwards and removed as en masse. So once that is done, then the whole organ system comes as a mass. So this is the en masse dissection. Here this is the tongue which is pulled from the structure. These are the lungs. Then this is the trachea, which along with the esophagus. The stomach is here. This is the omentum, and these are the intestine part. And here the pelvic organs, the kidneys, the liver are all attached. So this is the en masse dissection, where every organ is present in one single block and each attachment is preserved. After all the organs en masse dissection, spine is visible. The spine has to be examined for fractures. The atlanto-occipital joint should be examined by moving the head on the spine to note any fracture dislocations. Then examine the cervical spine for any fractures. Then thoracic lumbar spine should be examined by pushing a hand between the body to raise of the spine forward, which will show the abnormal movements of the side of the structure. To detect the fracture of the sacroiliac joint of the pelvic bones, the pelvic should be squeezed by side. So this is completely removed. So in next video we will discuss about each organ dissection, but separately how to remove. These are my references. Thank you.